All right, so get ready to dive into some cardiology today, specifically a phenomenon you might not have heard of before. It's called Ashman phenomenon, and it's something you often see on EKGs.
Yeah, it's one of those things that can be a little tricky, especially if you're not familiar with it.
So we'll break it down, make sure everyone's up to speed. We've got some good research to pick apart today, some journal articles, even a case study that I think will really bring it to life.
Yeah, it's definitely an interesting one.
So for folks who might not be as familiar, let's start with the basics. When we talk about these electrical signals in the heart, what exactly are we looking at?
Right, so basically your heart's electrical system, it's what controls your heartbeat, right? And an EKG, what it does is it records those electrical impulses. So every little blip you see on the EKG, that's showing you a different phase of the heart's electrical cycle.
It's like a roadmap of the heartbeat then.
That's a really good way to put it, yeah. Doctors use those roadmaps, those EKGs, to figure out what's going on, like if there are any problems with the heart rhythm, things like arrhythmias, even heart attacks.
So where does this Ashman phenomenon fit into all of this?
Well, with Ashman phenomenon, it's kind of like you were saying with the roadmap. It's like there's a little detour, a little hiccup in the way the electrical signals are traveling. Specifically, it's in the ventricles, the lower chambers of the heart.
Okay, so there's a detour in the ventricles, the lower chambers.
Mm-hmm.
But the heart's still beating, so what's the big deal?
The thing is, this specific kind of detour, it often pops up when someone has atrial fibrillation or AFib, which is a whole other thing.
Right, AFib, that's where the upper chambers of the heart, the atria, they're not beating in sync, right? They're kind of quivering instead of contracting smoothly.
Exactly. And, when the atria are out of whack like that, it can mess with the timing of those electrical signals going down to the ventricles, and that's where Ashman phenomenon comes in. But here's the catch. You can actually have Ashman phenomenon without atrial fibrillation, too.
Oh, so it's not always a package deal. That does make things trickier, I bet.
It does, yeah. And that's why it's so important to really understand what we're looking at with Ashman phenomenon, because you don't want to misinterpret it for something else, something that could be more serious.
Okay, so we've got this EKG finding, Ashman phenomenon. Sometimes it hangs out with AFib, sometimes it's flying solo. What about the patients themselves? What actually clues doctors in that something's up in the first place?
Well, that's where the case study comes in. We've got this 81-year-old man, and he comes in with some pretty general symptoms, things like swelling in his legs, fatigue, just not feeling his best.
So pretty general stuff. I imagine those could be signs of a lot of different things, not just a heart problem.
Exactly. But then when they did an EKG, that's when things started pointing towards Ashman phenomenon.
So the EKG is really the key here, it sounds like. What was it about his EKG that made them think, hold on, this could be Ashman's?
Well, there are a few things. They saw that long, short pattern in the heartbeats that we talked about earlier. And there's a specific way the electrical signals look on the EKG when you have Ashman's.
And that's different from how it looks with other heart rhythm problems.
Exactly. But here's the thing. They were really careful not to jump to any conclusions just yet because
it could have been something else entirely. Something way worse than just a little Ashman phenomenon.
Yeah, exactly. They had to make sure they weren't missing something else that could be really dangerous.
Okay, so they're being super careful, which is good. So how'd they figure out it was actually Ashman's? What'd they do next? So they're looking at this EKG, trying to rule out the really bad stuff, but they're also seeing signs pointing towards Ashman's. How do they start narrowing it down?
Well, they ran some more tests, which is usually how these things go. And in this case, those tests showed that, yep, he did have atrial fibrillation, which, like we were saying, is often where you see Ashman phenomenon pop up.
Okay, so the Ashman phenomenon, it wasn't a misinterpretation. It was actually there.
Yeah.
And it kind of tipped them off to the atrial fibrillation.
Exactly. It's like a little clue on the EKG saying, hey, there might be something else going on here, something you need to look into.
A little EKG whisper. So we've talked about how it looks on the EKG and how it can be a sign of AFib. But I'm still wondering, why does this even happen in the first place? What's going on in the heart that actually causes this Ashman phenomenon?
So to understand that, we need to get into a little bit of how heart muscle cells actually work. It's kind of cool, actually. So you know how after you use a muscle, it needs a little time to recover before it can work again?
Yeah, like if you lift something heavy, you can't just immediately lift it again. Your muscles need a sec.
Exactly. Well, heart muscle cells, they're the same way. They have something called a refractory period after they contract.
Refractory period sounds intense. What's that in a nutshell?
It's just a fancy way of saying that after a heart muscle cell contracts, it needs a tiny little break to get ready to contract again. Like, Think of it like a camera flash. After it flashes, it takes a second for it to recharge, right?
Right. Got to get that flash ready for the next awesome picture.
Exactly. So the refractory period is like that recharging time for heart muscle cells. Now, here's where it gets interesting with Ashman phenomenon. Sometimes, because of the timing of everything with the atria going kind of haywire, an electrical signal will reach a heart muscle cell during its refractory period when it's not quite ready to fire yet.
So it's like the signal is saying, go, go, go.
Wow.
But the muscle cell's like, hold on, still recharging over here.
Yeah, pretty much. And so when that happens, the muscle cell might not respond to the signal as strongly, or it might conduct the electrical impulse a little differently.
And that difference, that's what causes that short, long, short pattern we see on the EKG.
You got it. And often it's this one part of the heart's electrical system, the right bundle branch, that's a little slower to recharge than the rest. So that kind of contributes to this specific pattern we see in Ashman's.
So it's not just random. It all comes back to this refractory period, this recharging time. That's really cool. But how do doctors know for sure that it's Ashman's? I mean, EKGs can be complicated, right? Couldn't they mistake it for something else?
Oh, absolutely. And that's why it's so important to be thorough. Luckily, there are some specific things doctors look for on the EKG to make the right call.
Like what?
Well, they use something called the Fish criteria. Have you heard of those?
I think I saw them mentioned in one of the articles. What are they, like a checklist for Ashman's?
Basically, yeah.
Yeah.
They lay out a bunch of really specific characteristics of the EKG waves, you know, those little ups and downs on the tracing. And those characteristics help them tell the difference between Ashman phenomenon and other heart rhythm issues that might look similar at first glance.
So they're really looking at the nitty-gritty details of the EKG.
Yeah, they really have to dig in and...
Make sure it all lines up perfectly.
Yep, that's the name of the game.
So those Fish criteria, they're like the EKG decoder ring, making sure doctors are reading the signals right.
Exactly. It's all about being precise, you know, because when it comes to the heart, you don't want to mess around.
Absolutely not.
Well, first off, it's not Fish criteria, it's Fish.
Oh, right, of course. Fish.
Named after Dr. Charles Fish, a pretty prominent cardiologist who, you could say, wrote the book on heart rhythm abnormalities.
Oh, wow. So this is like big-time stuff.
Yeah, he was a pioneer. He was the first to really connect the dots between certain ECG patterns and, you guessed it, Ashman phenomenon.
Huh. And the criteria we still use today. That all stems from his work.
Pretty much, yeah. His observations form the bedrock of the diagnostic criteria. It's amazing the impact one person's work can have, right?
It really is. Speaking of observations, there's this line in the excerpt that mentions aberrant QRS complexes and RBB form aberrancy. I'm not going to lie, those terms sound a little intimidating. What's actually happening in the heart when those things pop up on an ECG?
I hear you. Those are definitely mouthful terms.
Right.
Medical lingo can sound pretty daunting. Let me try to demystify it a bit.
Okay, please.
So, picture this. The QRS complex on an ECG, it's basically the electrical signal that tells the ventricles to do their thing.
The ventricles being...
The heart's main pumping chambers, the workhorses.
Okay, got it.
Aberrant, in this context, just means unusual. So an aberrant QRS complex basically means that electrical signal's gone off course, resulting in a funny shape on the ECG.
Like a blip or something.
You could say that. Now, RBBB form aberrancy, that's a specific type of blip that looks a lot like what you'd see in something called right bundle branch block, or RBBB.
So it's like a clue within a clue.
Precisely. And what makes Ashman phenomenon even more interesting is that this usually happens because one of the heart's chambers is still winding down from the last beat when the next one comes along.
It's like it's trying to catch up or something.
Exactly.
Wow. So we've got these unusual electrical signals, these aberrant QRS complexes, but there's more to this ECG puzzle, right?
Oh yeah, there are a few more pieces to this puzzle.
The excerpt also mentions long cycles, irregular coupling, no idea what that means, and a short, long, short RR interval, which again sounds like a secret code. Can you decode those for us?
Let's see. Long cycles. Think of a cycle as one full heartbeat. So a long cycle is just a longer than usual pause between heartbeats, like the heart takes a little breather.
A well-deserved break, maybe?
Something like that. Irregular coupling just means those weird QRS complexes we were talking about. They're not exactly predictable. They pop up whenever they feel like it.
Keeping those cardiologists on their toes.
Exactly. And that long, short RR interval, that's a classic Ashman phenomenon calling card. 2 rapid heartbeats followed by a longer one. That distinctive rhythm is a big clue.
It's like the heart's own Morse code, almost.
Yeah, you could say that.
It's amazing to me how much information is packed into these, what seem to me like simple, squiggly lines. You're painting such a vivid picture. Are there any more secrets hidden in these criteria?
Oh, I almost forgot one. This one's important because it helps us tell the difference between Ashman phenomenon and other things that might look kind of similar on an ECG.
Okay. Yeah, that makes sense. What is it?
The lack of a fully compensatory pause.
Come again.
Basically, after a long cycle, like we talked about, the heart usually takes a longer pause to compensate. But with Ashman phenomenon, it doesn't. It jumps back in a little too quickly, which helps us be sure of the diagnosis.
It's incredible how doctors can look at an ECG and just put all those clues together.
It really is like detective work. It's fascinating, isn't it, how we can use technology to peer inside the body and decipher what's going on.
Absolutely. So, say they've used the fish criteria, and they're confident it's Ashman phenomenon. What happens next? What's the treatment?
Well, that's where it gets interesting. Remember how we were saying Ashman phenomenon itself isn't usually the main problem? It's more like a side effect of something else?
Right, like atrial fibrillation, that was the big one in our case study?
Exactly. So most of the time, you're not actually treating the Ashman phenomenon directly. You got to go after the root cause, the underlying condition that's causing it.
So it's like, if your car's making a funny noise, you don't just crank up the radio to drown it out. You got to figure out what's causing the noise in the first place.
That's a great way to put it. You got to fix the engine, not just mask the symptoms. So in the case of our 81-year-old patient, the treatment was focused on managing his atrial fibrillation.
And what about his Ashman phenomenon? Did that clear up once they got his atrial fibrillation under control?
It did, yeah. As his AFib got better with the medication, the Ashman phenomenon on his EKG, it just disappeared.
Oh, so it really was like a domino effect.
Yeah.
Knock down the atrial fibrillation, and the Ashman phenomenon falls too.
Exactly. And it just goes to show, with the heart especially, everything's connected. You have to look at the whole picture, the whole system, to really understand what's going on.
It's like a whole web in there.
Yeah.
And sometimes you have to follow a thread to see where it leads.
Exactly. And sometimes those threads lead to some pretty fascinating places. You know, that's what I love about cardiology. It's always a puzzle.
Well, I think we've successfully put together the pieces of the Ashman phenomenon puzzle today. What a journey. We've gone from EKGs to heart muscle cells to atrial fibrillation and back again.
It's been great breaking it all down, that's for sure.
So for anyone listening who might be seeing an EKG with that short, long, short pattern for the first time, remember, it might be Ashman phenomenon, and it's often a clue to something else going on in the heart.
Absolutely. If you have any concerns, talk to your doctor, ask questions, be your own health advocate.
Couldn't agree more. And on that note, we'll wrap up this deep dive into the fascinating world of the Ashman phenomenon. Until next time, stay curious, everyone.